Hello, everyone. This is Jim Henry. I first want to say what a great honor it is for me to be here to speak with you about tinnitus. And I thank the organizers, Michael, and everyone else for inviting me and giving me this privilege to talk to you about tinnitus for the next 30 minutes. This is a lot to cover: tinnitus clinical management, past, present, and future. But we'll try to hit the highlights, and hopefully this will be a good way to kick off this meeting. Just to give you a little background of who I am, my tinnitus journey started when I played loud music in my teens and in my 20s. I finally gave that up. I was a carpenter for 4 years after that, so a lot of noise, no hearing protection. Even when I was playing music, I knew I had tinnitus. I caused hearing loss. I have hyperacusis. I've got the works. So I've experienced all of this, and I really am careful to protect my ears now. Because I have a deaf daughter, I was interested in audiology. So I went back to school, got my master's degree in audiology in Portland at Portland State University. Right out of school, I got hired by Dr. Fausti and Dr. McDermott at the VA hospital in Portland to be a research audiologist, and I discovered how much I loved research. So I went back to school again. I went to Oregon Health and Science University, got a doctorate in behavioral neuroscience, and for the 6 years I was there, I was in the lab of Dr. Jack Vernon and Mary Meikle. And that's what really got me interested in tinnitus, was being in that lab, being in their clinic, and just being exposed to what they did every day to help people with tinnitus. So that really kicked off my career. Once I finished my program, I was still at the VA, went back to full-time at the VA, and wrote a grant about tinnitus, got it funded. That was 1995. I've been doing tinnitus research ever since. I retired from the VA in 2022, so I've been retired for over 2 years now. And my focus now is writing books about tinnitus and other auditory conditions. So here's my 3 tinnitus books that are currently available. They're all done. The first one, the tinnitus book, is just an overview of tinnitus, just all the details about tinnitus. Second book, Tinnitus Retraining Therapy. Third book, Progressive Tinnitus Management. And these books are written not just for consumers, but for everybody. I try to write in a way that is scientifically valid. I reference everything, and I try to make the language understandable by anyone in any field and even consumers. So hopefully these will be of value to you. I self-publish them to keep the costs down. And I've got more books in the works. This hyperacusis and misophonia book will be available in the winter. I'm working on that now. The tinnitus step care book will be the next one. Plural Publishing is going to publish that one. And then I have more after that. So writing books is my retirement hobby, and I'm enjoying that now. So let's talk about tinnitus. The basics, different forms of tinnitus. There's primary tinnitus and there's secondary tinnitus. So we are going to focus on primary tinnitus, which is basically nerve activity in the brain that is perceived as sound. It's all nerve activity and it's brain related. A secondary tinnitus actually is sound in the head that is perceived through the normal bone conduction mechanism. It's real sound with real sound waves, and we're not really going to focus on that during this conference. It's relatively rare, but quite a few people have secondary tinnitus, and they're the ones who need to see ENT and have a complete examination and potentially have their secondary tinnitus corrected. Now, secondary tinnitus is often referred to as objective tinnitus. Primary tinnitus can be referred to as subjective tinnitus or sensory neural tinnitus. So kind of take your pick, but I like the the designations primary and secondary because that was what was recommended by the American Academy of Otolaryngology Head and Neck Surgery Foundation in their guidelines that they published for tinnitus. And then there's also somatosensory tinnitus, also known as somatic tinnitus, also known as somatically modulated tinnitus. Now, this would be a variation of primary tinnitus. It is not secondary tinnitus. Somatosensory tinnitus means that your tinnitus sound can be altered by certain physical or somatic maneuvers, and there are ways to evaluate a person to see if their tinnitus can be somatically modulated. I've undergone that evaluation, and mine cannot. But apparently, at least 50% of people with primary tinnitus have a form of tinnitus that can be somatically modulated. So it's very common. It doesn't indicate that the person has any particular medical concerns, but it's something to be aware of. Often patients ask about it. They want to know, why does my tinnitus change when I turn my eyes to the right or when I touch my ear or whatever they say? It's very common, very normal, and nothing for them to be concerned about. So, like I said, this symposium is going to focus on primary tinnitus. So we'll start with the 1970s. I would refer to that as the modern tinnitus era. And back in 1972, if you do searches on PubMed and you put tinnitus in the title bar, you will find there were only 8 publications with tinnitus in the title back in 1972. And then fast forward to 2023, there were 475 peer-reviewed articles with tinnitus in the title. So there's a lot of renewed interest in tinnitus. There's a lot of interest around the world. A lot of researchers, clinicians are focusing on tinnitus. We're learning a lot, but I would have to say there's really no breakthroughs. And that's because there is no cure for tinnitus. There's the sound of tinnitus that can't be cured. So we have to address the reactions to tinnitus to help people to just live a normal life in spite of having tinnitus. So the first dedicated tinnitus clinic was Dr. Jack Vernon, shown here. And he started the OHSU, Oregon Health and Science University Tinnitus Clinic back in 1976. And he's known for pioneering the use of sound to do the masking method of treatment. He wrote a lot about that. I mean, if you've looked at the tinnitus literature, his name pops up all over the place. He co-founded the American Tinnitus Association, the ATA, and he retired in 1996, and he was taken over. His clinic was taken over by Dr. Billy Martin, who I also know well, and he's greatly respected in the tinnitus field. He's also retired, but sometimes he makes himself available for consultation. And the masking method is generally misunderstood. It's true that Dr. Vernon did try to cover up people's tinnitus to begin with. That was the original masking method. He soon realized he didn't have to completely cover up their tinnitus. He just needed to give them enough sound that they felt like they had a sense of relief from their tinnitus. So they could still hear their tinnitus, but they could also hear the sound. And he would turn it up to whatever level was comfortable for them. He typically used ear-level maskers. He was instrumental in developing combination instruments, hearing aids with maskers built in. And his method used a lot of counseling. Now, he's never really written up what did they do for counseling, but they just did a lot of counseling. And they, if you ever knew Bob Johnson was the primary counselor there, and he was compassionate and knowledgeable, and he just did a good job counseling. So masking was a combination of counseling and sound therapy. And then these are all other methods of counseling and sound therapy that have evolved after Jack Vernon's masking method. Now, CBT, cognitive behavioral therapy, does not necessarily include sound therapy, but the CBT practitioners will advise their patients to use sound in the background, and they'll advise them in different ways. So CBT is primarily a method of counseling, but patients are also advised to use sound as therapy. Tinnitus activities treatment was developed by Rich Tyler and his group starting in about 1987. Tinnitus retraining therapy, which most of you are probably aware of, was started by Pavel Jastroboff in about 1988. So these are all well-established evidence-based methods that are structured. They're written up. We know exactly what's involved in conducting these methods, and I would say any of these can work well to help patients with tinnitus overall. So CBT was applied to tinnitus by Robert Sweeto. Now that's interesting. He's an audiologist, and he's also retired now, but he was the first to write about applying CBT specifically to tinnitus treatment. And CBT has cognitive components, changing the way a person thinks about their tinnitus to be more positive and more constructive. Behavioral components are generally distraction activities, relaxation techniques, and then a lot of education about how to live life in a way that is more conducive to being less bothered by your tinnitus. And CBT is generally provided by psychological health providers. Anyone trained in CBT can administer it. Very few are actually available to provide CBT for tinnitus. So that is a general issue, that CBT has really the strongest evidence in the research literature for tinnitus treatment, and yet finding a CBT provider is often really difficult. There is now third wave CBT. I don't know if you know Bruce Hubbard. He is one of the proponents of using third wave CBT. So first wave CBT, or first wave therapy, was using different behavioral techniques. Second wave added the cognitive components. And then the third wave CBT, rather than using some of the techniques and the philosophies of traditional CBT, which would be second wave CBT, he and others have moved in the direction of people really focusing more on being aware of their tinnitus and accepting their tinnitus for what it is. Now, that's very different from distracting yourself from tinnitus. We could talk a lot about that, and hopefully somebody will in this symposium. We'd like to know more about that. But he has incorporated acceptance and commitment therapy and different mindfulness approaches. And that's basically what third wave CBT is. It's incorporating ACT and mindfulness. Pavel Jastroboff is given credit for developing tinnitus retraining therapy, TRT. The goal is habituation to the perception of tinnitus, habituation to the reactions to tinnitus. He's got 5 treatment groups, basically addressing do they have tinnitus, how bad is their tinnitus, do they have hearing loss, does their hearing loss present difficulties to them, do they have hyperacusis, do they have misophonia, and do they have reactive tinnitus? Don't have really more time to talk about TRT, but it's based on the neurophysiological model of tinnitus, which he developed. The counseling is very structured, and it's a lot of material to cover with patients. The sound therapy is critical. All patients are advised to avoid silence and enrich their sound environment. And the method is delivered mostly by audiologists, and probably thousands of audiologists have been trained in TRT directly by Pavel and Margaret Jastroboff and others on his team. Tinnitus activities treatment, there's Rich Tyler. It's been around a long time. It's also very well defined. It's been written up. There's book chapters and articles that describe it in detail. And it's another combination of sound therapy and counseling. He breaks his patients up into curious patients, concerned patients, and distressed patients. And it's like almost like Jastroboff's different patient categories, but mainly he's looking at how bothersome is the tinnitus for the person, and based on how bothersome it is, the level of services is provided accordingly. And mostly audiologists provide TAT. Progressive tinnitus management, that's the method that I helped develop. We first published about it in 2005. It's a stepped care method, so patients are only receiving the level of care that they need on an individual basis. Level 1 is the referral level, making sure they go to the right person to begin with to get the help they need. Level 2 is the audiology evaluation. Level 3 is skills education. That's really the counseling level, and it involves a combination of individualized sound therapy. So we don't subscribe to any one particular form of sound therapy. We just say patients need to be informed about how sound can be used to reduce their effects of tinnitus, and then you help them put together a program so that they use sounds that work well for them. And then they also receive components of cognitive behavioral therapy, some cognitive restructuring, some distraction techniques, and some relaxation techniques. And if they need more than that, we can do an individualized evaluation, which would be in-depth evaluation by both an audiologist and a psychologist. And if they need ongoing treatment, then we call that level 5 individualized support. And there's a telehealth version, which we've done randomized controlled trials on PTM and tele-PTM, and we've gotten very good results. So these are the established methods: CBT, TRT, tinnitus activities treatment, and PTM. They all use a combination of sound therapy and counseling. They're all well established. They're all evidence-based. So if you use any one of these methods, I'd say you are using a method that is generally going to be helpful to most people, provided you are a competent provider and you're really looking out for the best interests of your patient. And there are variations of these methods, and people often do vary the methods in different ways. There's a whole lot of methods that would be considered passive treatment, and they're all listed here. I'm not going to mention them all, but basically, what do they all have in common? They involve either taking some substance by mouth or receiving some procedure. All of these methods have been studied to some extent and are reported in the literature. So these might be considered promising methods. None of these methods has strong evidence of benefit, but they all have been shown to be helpful in some cases. And then that would be contrasted with behavioral or self-care methods, where basically the provider is teaching the patient what to do about their tinnitus, and then they go home and they do it on their own. And here's a list of these types of methods, and these are the methods that we generally use. All of the established methods that I mentioned would be considered behavioral or self-care methods. So what do they all have in common? Patients learn what they can do to manage effects of tinnitus, to sleep better, concentrate better, and not react emotionally to the tinnitus. Clinicians teach the techniques and provide support as necessary. Some self-care techniques can be learned without a clinician's help from various books, videos, and websites. So where are we headed? Where are we going in the future? I've got, looks like about 9 minutes left to try to cover this. Here's 4 different possibilities: bimodal stimulation, migraine-based therapy, repetitive transcranial magnetic stimulation, and sound therapies targeting the tinnitus sensation. So bimodal stimulation has a lot of buzz these days. The idea is to stimulate basically the dorsal cochlear nucleus with both auditory signals and somatosensory signals. And supposedly that induces more long-term plasticity in the dorsal cochlear nucleus neurons, and that is what supposedly reduces tinnitus. Now, there's no claim that I know of that it's going to reduce the sensation of tinnitus. It's another behavioral method. It's a method intended to help a person sleep better, to concentrate better, and to have fewer emotional reactions. So here are 3 different methods of bimodal stimulation. You probably heard of linear. That's this device with a tongue stimulator along with sound therapy. The Neosensory device is the Tinnitus Duo wristband. It's a vibrating wristband. Wish I had more time to talk about it, but I don't. Combined with sound therapy, so that's the duosensory aspect of this method. And then the Michigan tinnitus device, that's Susan Shore. It's not yet FDA approved. These first 2 are commercially available, and they're both FDA approved. Susan Shore is working on getting her device available to the public, but that has not happened yet. Otologic migraine, it's just interesting. This is Dr. Jay Lillian. I don't know if I pronounced that right, but he's been sort of the leader in this concept of otologic migraine. And basically, people can have migraines without headaches. Now, that seems counterintuitive, but it's really true. And so they could have the symptoms of migraine without the headache. Those would be considered atypical symptoms of migraine. And one of those symptoms is tinnitus. Another is hyperacusis. So they have a whole treatment regimen that they can use for tinnitus, and especially if they consider it to be otologic migraine-related tinnitus. So this is an up-and-coming technique to be aware of. Repetitive transcranial magnetic stimulation, rTMS. This is Bob Fulmer. He knows a lot about this. He's done clinical trials. He's written an article that really lays out the issues. This is a promising technique. It's used to treat depression and anxiety and other emotional disorders. It's used effectively. It has not really been proven to work well for tinnitus, but that does not mean it doesn't work. It just means there's more research to be done. Sound therapy is targeting the tinnitus sensation. So there's different ways to manipulate sound to try to have a long-term effect on the tinnitus. One of those is to notch the sound around the tinnitus frequency with the idea of flooding that frequency region with lateral inhibition and reducing the sound of the tinnitus. Now, this could be a cure or a partial cure if they can figure out how to do this on a consistent basis, how to evaluate a person, design a notch noise therapy for that person, and deliver it effectively. We're just not there yet. The rationale is good. There's a rationale for believing this should work, but the research has not yet been done to prove that it works. Same thing with matched noise therapy. It's just a different concept. Instead of trying to notch sound around the tinnitus signal, you're matching the tinnitus with noise around that tinnitus region. And the idea is to counteract the reduction in activity going into the dorsal cochlear nucleus, and by counteracting it, you are increasing the activity going to the DCN, which reduces the activity taking place in the DCN, which basically is trying to normalize what the DCN is doing when it has normal auditory input. That probably didn't make much sense, but you're trying to restore homeostasis in the dorsal cochlear nucleus. And so then there's a good rationale for using this, but again, we just don't have the proof that it works. Neurodesynchronization therapy. This works on the assumption that the reason we have tinnitus, or the primary reason, is because of neural synchrony. That hearing loss causes this neural synchrony. It's the neural synchrony that produces tinnitus. So they have developed a way of delivering sound in a way that supposedly disrupts that neural synchrony to establish normal activity of the auditory central nervous system. There's a company called Desynchra that has since gone out of business. I'm not aware that they that they've restarted this company. Residual inhibition, I believe that has promise. But again, the research hasn't been done. We know that if we do this for people, we give them sound at a level above the minimum masking level for about a minute. We shut it off. We ask them, what does your tinnitus sound like? And 80 or 90% say it's softer or it's gone. And I can do this to myself over and over and over. The problem is the tinnitus returns within a few minutes. Now, there are methods that have been tried to extend the duration of residual inhibition. There's some research going on. In my mind, not enough research. I think this method really has potential as a clinical technique, but again, we're just not there. There's all kinds of experimental methods, and because I'm running out of time, I'm not going to list them all or talk about any of them, but a lot of them involve electrical stimulation in different ways. So in summary, and I think I'm good on time, there's no cure for tinnitus. All methods address effects of tinnitus: sleep problems, concentration difficulties, emotional reactions. We certainly need a cure, and there's research going on around the world. One of these days, somebody's going to find it, and there's probably many different cures. There's different subtypes of tinnitus. We don't know what all of them are yet. That's more research that needs to be done. We are at a point where many methods can effectively treat the majority of patients. We have these established methods that I talked about. We have all kinds of forms of counseling. We have unlimited forms of sound therapy. And there's practitioners, clinics, methods, websites, apps, and companies that provide different forms of tinnitus management. So there's a lot out there. Not a lot of it is proven, but it can be helpful if conducted properly by competent providers. There's no proof that any one method is more effective than any other. All methods of tinnitus treatment may elicit the placebo effect. Competent providers should use whatever works and is in the best interest of patients, including safety concerns and costs. So we need more research, obviously. We need a credentialing program that verifies that a clinician is competent in providing these services. We need standardization of services. And one way to achieve standardization is to develop a learning health network. And we have a presentation on this coming up later, a tinnitus learning health network. And that would be a network of clinics that are all working together and communicating with each other and getting a lot of patient input to determine what is best practice. And what could really benefit from that type of approach is that we could figure out what kind of patient does best with what kind of treatment. So we really need to get to that point. I'm also going to talk later about a method called tinnitus stepped care, and that would be an overall framework for providing tinnitus services without dictating exactly what should be done. And then lastly, this living guideline concept. This is an article that I would strongly recommend everyone take a look at. Languth et al., 2023. They came up with this idea. We need guidelines for tinnitus. We need people to systematically evaluate what's going on in the literature. We can't wait years and years and years and years for our clinical practice to actually change as a result of the research. With a living guideline concept, we would have people continually reviewing the literature in real time and adjusting their guidelines based on this real-time evaluation. It's a brilliant concept. It would just require funding. It would require individuals being hired to do this job, but it's feasibly, it could be done feasibly, and I think it's a great idea. So in conclusion, the ultimate goal, and this is from the Languth article, the ultimate goal is to help the tinnitus patient. Clinicians should have the leeway to choose appropriate treatment, even if the quality of evidence is low, which is the case for most treatments. A holistic approach that considers all factors should be used in making clinical decisions. So that is it. I'm going to leave you with some contact information. I will make this talk available as a PDF with all the slides on it. So that's it. Thank you so much for listening, and I look forward to the rest of the symposium. And I thank the organizers once again for inviting me and letting me participate and kick off this meeting. Thank you.